Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. Welcome, YouTube. Peace, peace. All right, so we pick up in the 30th chapter. Yes! It's been so good that we've gotten this far. So, pick up at page 445, right at the top. There we go. Lymphatic function. Episode number 74. The ultrastructure of the pulmonary interstitial space has been described. See Chapter 1. A constant flow of fluid and electrolytes normally exists from pulmonary blood to interstitum. Likewise, a constant removal by the lymphatics of these substances, along with protein, normally occurs. Since interstitial pressures are less than right atrial pressure, the lymphatic flow must be due to active mechanisms. Although the lymphatic ducts have peristaltic capabilities, the mechanisms by which substances are transported to the ostia of the lymphatic ducts are completely unknown. Reasonable theories include the autonomic nervous system, smooth muscle contractions, and cyclic lymphatic mechanisms removes cyclic lung movement. Regardless of specifics, a combination of complex lymphatic mechanisms remove sodium chloride, proteins, and water from the interstitial space. Thus, the net result of sodium and protein content within the interstitum is at least partly dependent upon lymphatic function. Generalized failure of lymphatics is seen as asthnica or anasarca, interstitial edema of the entire body that is believed secondary to both endothelial and lymphatic malfunction. However, most non-cardiogenic pulmonary edema occurs independently of systemic interstitial edema. Perhaps this results from failure of mechanisms responsible for transporting fluid, electrolytes, and proteins to the lymphatic duct ostia rather than from failure of the lymphatics proper. Are such mechanisms influenced by alveolar type 2 cells? The answers are not known. Endothelial function. The metabolic function of pulmonary and systemic endothelial cells has been discussed. See Chapter 1. Pulmonary endothelium is more porous than most other organ systems except the kidney and liver. The exact mechanisms involved in determining pulmonary endothelial micropore size and function are not known. Since some endothelial cell functions have been demonstrated to be sodium dependent, perhaps similar mechanisms control cytoplasmic function in terms of pulmonary capillary macrophages. Micropore malfunction, endothelial cell abnormality occurs in numerous disease states in which type 2 cells appear normal. However, almost always when type 2 cells are abnormal, endothelial micropore function is found to be abnormal. A clinical concept of ARDS. We are in the 30th chapter, Adult Respiratory Distress Syndrome, or ARDS. Thank you so much for the likes and subs. We're pushing towards 600 on this peaceful part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Riley. Thank you so much. We're at the top of page 446. A clinical concept of ARDS. The authors present clinical concept of ARDS, table 33, is based on available information and on the applicability of the schema to clinical practice. By no means should this concept be considered complete or unchangeable. To the contrary, it is presented as an incomplete schema that has undergone and will continue to undergo significant change as new information and further experience are gained. And here we go. This is table 33, proposed common pathway of ARDS. And you'll see the type 2 cell malfunction at the top, non cardiogenic pulmonary edema, and then lung compliance diffuse. Then the FRC, atelectasis, true shunting, and arrows, all directing from work of breathing, hypoxemia, and shunt defect, and refractory hypoxemia all from the surfactant. And you'll see right here, FRC equals functional residual capacity, as we've spoken about before. Thank you so much for reading with us in the 30th chapter, Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So there you go. All right. Alveolar type 2 cells are exceptionally vulnerable to physiologic stress. When significantly stressed or damaged, they attempt to meet metabolic demands by proliferation and hypertrophy, inevitably resulting in metabolic malfunction. Such malfunction leads to 1. Decreased production or abnormal production of pulmonary surfactant. 2. Interstitial sodium and water retention. 3. Suboptimal interstitial lymphatic function. And 4. Endothelial cytoplasmic abnormality, woof, causing micropore enlargement. These factors lead to a diffuse and relatively homogeneous lung abnormality with 1. Decreased lung compliance, primarily due to surfactant deficiency and secondarily to the interstitial edema, and 2. Non-cardiogenic pulmonary edema, primarily due to leaky capillaries, allowing increased colloid to enter the interstitum, and secondarily due to increased sodium retention in the interstitum. A non-diurizable urizable edema secondary to deficient sodium pump function of the type 2 cells, and both of these compounded by a decreased lymphatic function. Woo! Woo! That's the real deal right there. 447 in the middle. Here we go. This is for all those taking notes and in the replays. This is a big one right here. Pin drop. The diffuse decrease in lung compliance results in a significantly decreased FRC due primarily to the surfactant abnormality. The gravity dependent alveoli will begin to collapse, resulting in atelectic lung that is relatively well perfused. As this process continues, it results in a refractory hypoxemia. The continuing decrease in compliance requires greater muscular energy to inflate the lung and therefore increase the work of breathing. Ding! Increased work of breathing. Why? Because it's less lung compliance, right? There's the pores are bigger, there's more being caught in there and held in there, and there's more going in and out. The interstitium. So powerful, so powerful. Based on this general schema, figure 31, a rational discussion of the clinical management of oxygenation supportive care is possible. All right. All tissues. That's what mattered in that point. I wanted to point that out. All right. Principles of oxygenation support in ARDS. ARDS represents a serious oxygenation threat to all tissues. Its management must be aimed at supporting tissue oxygenation through optimization of cardiopulmonary function. In the 1950s and 1960s, such therapy consisted of high inspired oxygen concentrations to support the hypoxemia and of positive pressure ventilation to support work of breathing. The results of this therapy were dismal, the patient almost always dying from overwhelming lung pathology. Alveolar oxygen tension. Did a lot of work today. Did a lot of work today. Thank you so much. The biochemical sequelae of alveolar epithelial cell hyperoxia have been discussed in Chapter 7. Normal alveolar epithelium is exposed to oxygen tensions greater than 350 to 400 millimeters Hg. Cellular dysfunction becomes apparent in several days. In fact, 100% oxygen delivered to normal lungs over several days will directly result in epithelial cell damage. In addition, previously malfunctioning type 2 cells may undergo rapid degeneration when exposed to alveolar oxygen tensions as low as 250 millimeters Hg. Since inspired oxygen concentrations of 40% at sea level will result in alveolar oxygen tensions of about 250 millimeters Hg, it would appear that an FiO2 of greater than 40% would be potentially detrimental in ARDS. Superficially, it may appear a paradox to discuss minimizing FiO2 in a patient with severe hypoxemia. Remember, these patients have refractory hypoxemia and will have essentially the same arterial oxygenation with 50% inspired oxygen as with 100% inspired oxygen. Also, a pulmonary death is virtually guaranteed if high inspired oxygen concentrations are continued. Middle of page 448. In this 30th chapter, positive pressure ventilation. Appropriately administered positive pressure ventilation to normal lungs may be maintained for prolonged periods without pulmonary damage. However, excessively high pressures within the lung are believed detrimental to type 2 cells. Thus, positive pressure ventilation would be anticipated to be detrimental in ARDS, since the poor compliance usually requires excessive pressures to accomplish ventilation. A spontaneously breathing patient receiving 40% oxygen or less would not be expected to develop ARDS from the oxygen therapy. A patient on appropriate positive pressure ventilation receiving less than 40% oxygen would not be expected to develop ARDS from the ventilator. However, a patient on PPV receiving 100% oxygen would be expected to develop ARDS within several days. This is probably why the therapy of the 1950s and 1960s, PPV plus 100% oxygen, was so uniformly unsuccessful. And here we go. This is figure 31. right? And represents the normal relationships between lung volumes compliance and VA over Q. B represents the changes that occur in ARDS. See text. IRV equals inspiratory reserve volume. VT equals tidal volume. ERV equals expiratory reserve volume. And RV equals residual volume. And we have this on the front of the cover of the book, right? As you see, because that's what this is all about. The respiratory system, how to better it, mastering thyself, mastering thy breath, right? This is the most known self powerful healing mechanism is the diaphragmatic breath. So I'll let you put the dots together. That's why I read these books on here and they're for free. Because there's going to be some little boy or a little girl that comes across these videos and just be inspired because they say, he said I can do it. He read it. He's reading it to us. He wants us to have this information. Yeah, I love it. I love it. I love it. Here we go. This is figure 31, A and B. Remember, B represents the changes that occur in ARDS. Okay, it's the smaller. And this again is on the front of the book, right? Thank you so much for being here and reading with us. Clinical application of respiratory care. It's all about the care, having care. Well, this is what it means to have a heart. Happy solar return to CJ, highest heart love. Happy solar return to Zaza Ali. We love you. Thank you so much for all your work. Highest heart love. All right, here we go. PEEP therapy. No single therapeutic intervention is more essential in ARDS than the appropriate application of PEEP therapy. ARDS can be received uh, as an acute restrictive disease in which FRC is greatly diminished owing to a relatively uniform metabolic malfunction throughout the lung. Therefore, the pathology matches almost perfectly the theoretic principles on which the application of PEEP therapy was discussed in chapter 25 or 24. In general, ARDS is a relatively homogeneous, acute restrictive disease that is exquisitely amenable to reversibility toward more physiologic circumstances with appropriate application of PEEP therapy. Two crucial pathophysiologic processes are apparently reversed with appropriate PEEP therapy. One, the decreased FRC is increased toward a more favorable position on the lung compliance curve. See figure 31. This results in a decreased work of breathing for the patient or lower inflation pressures on the ventilator. Two, the expansion of FRC favoring those areas of lung previously collapsed, see chapter 24, will result in a significant reversal of true intrapulmonary shunting. Therefore, the refractory hypoxemia will become responsive to oxygen therapy, which will allow appropriate arterial oxygen levels to be achieved with relatively low inspired oxygen concentrations. From a pulmonary viewpoint, the applications of PEEP therapy is absolutely appropriate and indicated in ARDS. However, we must always consider the potential deleri- deleterious effects on cardiovascular function. It is clear that any increase in airway pressure may cause some degree of increase in interpleural pressures. As discussed in chapter 24 and 27, the degree of transmission of increased airway pressures is dependent upon the severity of the decreased lung compliance. In other words, the less compliant the lung, the less portion of increased airway pressure that will be transmitted to the pleural space. Thus, the more severe the ARDS, the greater should be the cardiovascular tolerance for high levels of PEEP. However, PEEP therapy cannot be increased indiscriminately. Once a reasonable effect has been accomplished, i.e., FRC and lung compliance significantly restored toward normal, a greater portion of any additional PEEP will be transmitted to the pleural space. The abundance, right, goes into filling the pleural space. Ding! Must put a pin right there, right? It's never just nothing there, right? Especially when we're dealing with respiratory and lung compliance, capillaries, cells. It's a beautiful thing. It's a beautiful thing. This brings to the fore the questions. How much PEEP is clinically adequate? How does one appropriately monitor PEEP therapy? Let's keep going. All right. Monitoring PEEP therapy. The effects of PEEP therapy on intrapulmonary shunt compliance, arterial oxygen tension, and cardiac output in the ARDS have been voluminously studied. Voluminously studied. Figure 32 combines this information into a schema that assumes that the starting point is severe ARDS. As increasing levels of PEEP are applied, 1. At some point, arterial PO2 will begin to improve and continue to do so if FiO2 is kept constant. 2. Interpulmonary shunting, QS over QT, will decrease. And 3. Effective static compliance, ESC. See chapter 24 will improve. All right. However, if PEEP is increased too far, the compliance will begin to decrease. Note that the significant improvement in arterial PO2, intrapulmonary shunting, and compliance tends to occur in the same PEEP range. This appears reasonable since it may be assumed that reversal of the underlying pathophysiology, decreased FRC, is responsible for all these changes. The effects of any PEEP level on cardiac output are believed dependent upon the cardiac reserves, availability of adequate intravascular volume, and lung compliance. Patients with a healthy heart will show minimal cardiovascular effects with increasing PEEP levels so long as fluid therapy is adequate. Increasing PEEP levels in patients with limited cardiac reserves may manifest decreased cardiac output prior to or coinciding with significant increases in arterial PO2. We'll pause right here, continue back, as you see, with Figure 32 is a schematic representation of what they were just speaking about. So I'll show you that before we close out. Highest Heart Love. Thank you so much for reading books with us. Love to all of you here on YouTube and the book lovers community. So while we do that, peaceful place. Got to give you the peace, right? All right. So this is Figure 32. And you'll see the CO at the top, then the QS over QT, and the ESC and the PaO2. And they all intersect in this black shaded area. Okay, and it says schematic representation of expected changes in cardiac output, or CO, right? Intrapulmonary shunting, which is the QS over QT, effective static compliance, which is the ESC, and the arterial PO2 or the PaO2 as PEEP is increased. The schema assumes that the starting point represents severe ARDS. See the text, which we just read. PEEP equals positive and expiratory pressure. The black area represents the PEEP level of greatest physiologic advantage, assuming cardiac output remains adequate. Here we go. Close out. We had a wonderful packed day today with the grocery giveaway here at South LA Cafe. Man, we gave out loads of groceries, all apples and pears and grapes and just all goodness to the people. Thank you so much. You see how it all intersects in that black area, okay? Remember, too much will make it decrease. All right. So we'll continue back in the 30th chapter when we reconvene page 451. All right. And that is where we'll pick up at next time. Thank you so much for reading with us. Highest heart, love, and honor. Let's have a glass of love water, right? Oh, yep. I gotta go get it. Go grab the love water. Oh, yeah. Nice. So we've been doing some greatness here in South LA Cafe, and I just want to share with y'all. Appreciate you. And just a few birthdays, solar returns. We got the full moon as well, right? So, beautiful day. Wanted to make sure I got on here, bring the reading, and maybe let it sit for a little bit because I know it's a lot of information. I will put the vocabulary in the description. All right. Highest heart. Thank you so much for being here with us. All right. Shake it up on YouTube, reading books, right? Doing the healthy and right thing for our people. That's what's always best. So, there's no skipping levels. We have to go through all the levels. That's what we learn. Like I was saying earlier, it's going to be a child in the future that may need to feel direction, may need to feel love. They're going to be able to say, I know one person that loves me. And they're going to say, how do you know he loves you? And they're going to say, because he sings it to me. He presented love water to us. Oh, highest heart, love, and honor. CJ, we love you so much. Wonderful singer. If you go to my social media, Instagram pages, or if you follow any of my playlists. CJ is one of my great friends here at South LA Cafe. Helps us groceries giveaway. Also a wonderful actor, and so it's just his solo return, and he's also in my playlist. So if you ever hear the song, "There's something in the water," I know that's him. So highest heart love to you, the great Zaza Ali as well, and all the work that you've put out there. Highest heart love. Thank you so much. We love you. I love you. Mm. Oh, I love you. I love you. I love you. Thank you so much for reading with us. Highest heart love. Taking it up. Live from the light. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Highest heart love. Thank you so much for reading with us when we reconvene in chapter 30. We're doing it. Thank you so much. I will put the vocabulary in the description. We have another Your Healing session tomorrow. So it's going to be another busy day. Heal the people. That's what we're here for. And a wonderful meditation with the great Lorianne Speed today. Thank you so much, Lorianne Speed. Love to Canada. Love all the way here from LA. Love to New Jersey. Love to Florida. I love you so much, Mom, Dad, Isis, Tamika, Marquise, Tyron. I love you. I love you. And you know it. I love myself. Eyes on love. I'll see you soon.